Welcome to the Byja radio show. I'm your host, Dr. Byron Jasper, and we are recording live from J. Kinba Executive Suites in Baton Rouge, Louisiana, with special production by Becnel Media. All right, we are back. Thank you for coming back and checking us out at the amazing Byja radio show. We are here today with the stupendous, magnificent, world-renowned, kissing babies, shaking hands, Mr. One and Only Patient Zero, George Becnel.
Hey, man, let the record show I did not give Byron a 20 to say all that good stuff. So thank you, Dr. Jasper, for that fantastic introduction, man. Really appreciate it.
It was a 10, but hey, we got to start somewhere.
That's a little gas money.
No gas, not
much gas money. Not like back in the day, but it'll get you around the corner.
Lawnmower gas money is what I'm thinking. So,
hey, you need to mow the lawn. You got a nice little lawn out there.
There we go. So we are at episode 10. Man, we are in the double digits.
What?
Right? We have literally hit the double nickel. So we appreciate the idea that we have made it this far. And of course, we appreciate the idea that we have some dedicated listeners. So we again say welcome back, but thank you for listening in. Today we have a interesting topic. Mm-hmm. I think all of our topics are interesting, but this one is a little more interesting because it kind of started outside of the U.S.
Mm-hmm. Check us out. We global.
There we go. Well, people from a global background are actually listening to us, which is interesting, right?
Love it.
Someone literally came and said, hey, there's something going on outside of the country, and I wonder if this is relevant. Mm-hmm. And they asked a unique question. So we'll go ahead and cue it up as we normally do, have the question come across, and then from there, we'll go ahead and kind of give our take. So, George, if you will.
Got you.
Hi, Dr. Jasper. My name is Alexander, and greetings to you and Patient Zero from your listeners across the pond. I've been hearing a lot about the GP contract protests in the UK and how they are affecting both doctors and patients. It seems like these protests are happening for reasons similar to what you've discussed in previous episodes regarding issues that happen in the US healthcare system. Can you share thoughts on these protests and how similar issues could be addressed differently in the direct primary care model you practice at Byja Clinic?
All right, so I will just start by saying, definitely love the accent, right? Anytime Absolutely. You have somebody who is possibly talking to us Americans, the accent usually is a huge bonus, right? So with us, love the accent.
Yeah.
Definitely made me feel, cultured, maybe.
Yeah.
So
and look, I'll spare y'all my British accent for the day.
Please.
I will spare y'all.
I appreciate that. That means we've made it a little bit further in life. So, But as for the question goes, so let's give a little bit of background. So one of the things that they mentioned is that there is a potential protest happening where the British Medical Association is considering having a protest against the contract that they have with the United Kingdom or the UK. So again, that medical association or the governing body that a lot of the doctors partner or become a part of, they are actually having an idea of, look, conditions are really bad, and we are thinking that we need to protest as a organization to prevent us in primary care from having a problem with this contract.
Okay.
And I think that's something that a lot of people may not understand because, of course, a lot of people think, look, healthcare in America is kind of how it is globally.
Sure.
And that's not the case, right? So what we're having in the idea that they're not protesting quite yet, they're thinking about it, but that protest kind of highlights how primary care can be problematic in other areas, even when you have a different setup, but certain things are still kind of a theme that runs throughout.
Okay, so let's before we go any further, let's kind of like break this down a little bit, because you said healthcare isn't like what it is in America, right? And then you mentioned these British contracts, right? So question is, who are these British contracts with? What do they actually do? As well as, is there a domestic counterpart to these contracts? Like, is there like an American version of what's going on with these contracts?
Yeah.
Because I just want our listeners to to be able to, like, we appreciate our global listeners, but as far as our domestic listeners, I want them to be able to kind of connect the dots, if that makes sense.
Makes sense. No, so great questions. I'm going to go ahead and say thank you, George Gumble, because those are some really good questions, because some of the stuff that you're asking, I had the same questions.
So I'm the third Gumble brother now?
There you go.
Oh, man, I'm in good company, boy.
There you go.
I done came up in the world.
There you go. So for me, I had some similar questions, right? What do they mean by a contract between a medical association and what sounds like a national, somewhat almost government association, right?
Sure.
So in the UK, apparently they do something for primary care called a General Medical Services Contract, or a GMS contract. And this is the most common contract that's negotiated through the British Medical Association and the National Health Service of England, right? The National Health Service is basically like the government entity, and then the body of medical professionals in the British Medical Association have a contract together that outlines how primary care is delivered to the people in that area. So again, it's no insurance per se, but there is a third party that kind of comes in and negotiates or mandates or sets the expectations for these general practitioners. They go by GPs over there, not family medicine physicians or family medicine docs. They usually say GPs or general practitioners. We say that here sometimes, but the GPs have a contract directly with that governing body. They may not necessarily say it's the government, but it's a governing body. So that governing body is National Health Service of England. In that contract, again, it lays out how many patients they see in a day, what services are provided to those patients, what is covered, how many people are on a panel. It really kind of lays out everything, and it sounds very similar to insurance.
Right.
It literally specifies almost day to day exactly what an insurance company does here. And when that insurance company or governing body sometimes gets involved, it can get messy. So to connect the dots in a very basic way, that GMS contract is the biggest and most standard contract out there. It may not necessarily be the only contract, but some people may look at it like a Medicare compared to what we do here, right? So the Medicare is usually the biggest contract because it's a federal contract, and it kind of dictates and mandates things from a federal level. So that GMS contract would be similar to that. There's also a personal medical services contract and an alternative provider medical services contract. So those two contracts are more local. Some may think more of a Medicaid or something like that, where it's more state level. But the GMS is the big one, and that one is the one that's causing all the ruckus, if you will. And it's because the physicians over there are saying, look, we're fed up, we're frustrated, we don't really want this to continue to where we're basically getting all of these problems, and we're just going to keep on doing it and doing it and doing it until we eventually burn ourselves out. And of course, we talked about that last episode, how burnout is a main thing that happens to people when they're just overworked, and it just keeps getting worse. But this is kind of a huge ripple because the practitioners over there are saying, look, enough is enough. We're going to do something about this. We're not just going to keep working and put our heads down and have no say so. And the hope is that with that potential protest, things are going to change. And believe it or not, things are already changing. They're actually starting to see movement from the National Health Service of England that are coming back and saying, well, we do want to renegotiate this contract because we don't want to eliminate primary care and cause people to go without service. So we can talk more about what those mandates are, which have a lot of similarities to what we talk about almost weekly. But it definitely highlights that it's not just a America thing that has a problem where primary care is kind of a afterthought. It's a issue that we see regularly, that if you have certain people negotiating and mandating things and they're not necessarily in the room with the patients, you don't realize that they're possibly causing a lot of trouble that other people have to clean up or fix or deal with. So I think overall that's kind of huge that people can start to align those two things, where the contract that the national entity is having with this medical association is similar to maybe a Medicare having a problem with other people in the states. And then you can also see some of the things that I'll highlight really quickly that are prominent in the contract that are problematic. You'll start to say, okay, I kind of get where they're having some pushback. So any idea, George, where some of these problems may be if you say, okay, we have a government entity that's coming in and telling doctors how to practice, if you will. Where do you foresee there being problems now that you've been in the DPC model and you know kind of what we deal with and talk about all the time? What do you think that the doctors over there and the British Medical Association are saying, hey, these are problems we're having and we need to renegotiate this contract?
So if you're telling me that, just is as I guess a lay person, for lack of a better term, somebody who's not in the healthcare industry, it just sounds like you mentioned that the British government is more like an insurance, right?
Very.
So if they are regulating things, I'm assuming that they're regulating or requiring you to see X amount of patients per day, and maybe the pushback is something that we talked about either last week or week before. I don't remember. It's people getting, burnt out. You're not really getting a good level of care if your goal is to see X amount of patients per day instead of just trying to take care of each patient that you got in front of you. So I would assume it starts there. Maybe they're overworked as well, like we talked about some of the same issues in America last week.
Yeah, so I think that's the first and most prominent problem that they're talking about, right? It's seeing so many patients per day that they're not able to deliver quality care. So over there, they're trying to put a hard limit on how many people the physicians will see a day. Over here in America, that limit is pretty arbitrary. Why do I say arbitrary? Well, technically, if you're in a insurance-based practice, you could see 5, 6, 7 people a day. But number one, for overhead purposes, how much is that going to cost you where you're only seeing 5 people, but you have to pay all these other people out of those 5? Your take-home pay or your take-home revenue is going to be so low that at that point you really can't have a business. So even though you can see less here, there's no mandate on how many you have to see. We know most of the time you have to see sometimes upwards of 30 or 40 people a day in private practice, especially in insurance-based practices. Well, over there, they're trying to mandate that people have no more than 25 patients in a day. No more, meaning, look, when we hit 25, we're done. And so some people, they may say, well, 25 still seems pretty high. Well, it could be, but if you're seeing 50, right, it's a huge win to go from a 50 or 40 or 45 in a day down to 25. So I think we're starting somewhere. But that's one of the biggest complaints is we're seeing so many people, this is not sustainable. So how do we take it back and cut that number down and make it to where it's a hard number that we don't go above? And I think that's the first and biggest thing. And of course, the domino effect thereafter is, hey, we reduce the number of people we're seeing a day. We're going to hopefully have less burnout because we're not seeing too many. And by seeing less, we have less things that come downstream, which are more of the administrative effects. So any other idea besides the number of people per day that they're potentially trying to push back against, right? We don't want to see any more than 25. What other things would you think maybe in this contract they're trying to protest and possibly renegotiate?
So just listening to what you just said, I would assume that, all right, if you're seeing upwards of 50 patients a day, and you have all this overhead, you limit it at 25, there's a lot of revenue that's being missed, right? So I would assume that there would be some type of money gap that maybe they say, well, look, we need to make more money per patient, maybe as part of an issue.
Yeah. And that's one of the things. So they don't necessarily say money per patient or what we would say is fee for service or price per patient. What they're doing and they're calling it is basically funding, right? They're trying to get more funding to allow them to practice medicine the way that they would practice. In the UK system, they have something called capitation. And in the capitation sense, what you're really and truthfully dealing with is kind of what we deal with here. In that system, you're basically having someone come in and say, we're giving you X number of patients. And if you're seeing X number of patients, we're going to pay you this amount because you're caring for this many patients. So in that framework, the goal for the primary care team the British Medical Association specifically is to say, well, if we're going to take that many patients, we want to be paid more per patient. And if we are paid more per patient, we probably don't have to see as many patients, right? So it's the same concept, but it's a slight difference, right? Some people would say, well, if I see less patients, as you just said, I'm going to make less money. Well, they're smart enough to know that, look, we're not going to just see less patients and say we are okay making less money. We want to be compensated for the work we're doing.
Correct.
And the follow-up to that is, how do they do it? Well, they're working on something called a quality and outcomes framework, which basically says we're not paid by the volume. What we're paid for is by the quality of work we deliver. So for those 25 patients, if we're doing a really good job and we're doing excellent work of keeping them healthy and keeping them alive, we should be paid more. And emphasizing prevention rather than sick care, emphasizing quality over quantity. And that's the two things that are the biggest points in this. It's not just volume that we're trying to reduce and still give mediocre care. It's we're going to decrease the number, but also increase the quality.
But see, that to me, raises another issue, because I feel like sometimes that's a little hard to track.
Yeah.
Like how do you track, because you would almost have to follow a patient for like a year or two after you've seen the patient, number one. And number two, just being in this American insurance model so long, sick care is more profitable
Absolutely.
than preventative care.
Absolutely.
So I'm just wondering, like I get their points from a place of morality or a place of what should be in a perfect world.
Yeah.
But in terms of an economic perspective, I don't see how that works. So I'm a little curious how they're going to structure it and how that benefits everybody involved.
Well, let's explore that. Let's take it away from the UK system and just talk about it in general. I think what we are seeing in traditional care in America is that we have found a way to monetize sick care way better than we have found a way to monetize
Very true.
preventative care. If we probably got enough smart people in the room around the table and say, well, how much does it cost to do something healthy, and literally work backwards on, well, it costs this much to do, walking for an hour. It costs this much to have a healthy diet, right? We work backwards from that number. We can start to probably incentivize how much it would be to go to primary care and have a better outcome than it is that, look, you just had a triple bypass. We know it costs $30,000 or whatever the number may be. I think that's the problem, right? As you just said, it seems to be backwards that we're going to emphasize primary care, prevention as well, and somehow make more money. Well, I think that's because the emphasis is placed on sick care, especially in America, right? We want to believe that America is spending lots of money in healthcare and having amazing outcomes. I just gave a lecture probably about 2-3 weeks ago at a few universities, and at that lecture, one of the things I highlighted was that we may be in the top 5, if not the top 10 in healthcare spending across the globe, but oftentimes are nowhere close to the top 25 in healthcare outcomes. So we spend way more than most countries, but have worse health outcomes. So it goes to show you that the spending that we're doing is not equating to better health outcomes. So to me, why keep doing that? Well, we keep doing it because that's what we know. It's hard to break the system that people feel comfortable in. It's hard to get them out of the thinking, well, I'm going to lose money if I go away from what I know. Well, no, you may lose money if you don't think and become innovative to find a way to replace that spending in category A with something in category B, and it gives you multiple things. But let's go outside of healthcare. You have certain restaurants that literally are great, that they only serve one thing, and if you tell them to serve something different, it might actually cause them to lose money. But the really good, timeless restaurants and companies have more than one product. And that product oftentimes comes through innovation that, look, if this thing is falling by the wayside, we need to pivot and go elsewhere. And that's how I think healthcare can be, but a lot of people don't want to do that. It's too difficult to think outside of sick care because we found ways to put dollars and cents on things that don't necessarily have dollars and cents. But once we do it, we now know that's what it is, so we just stick with it.
Well, I think what you're proposing and is beneficial to physicians and patients, right? But I also realize that a big player in this is the insurance companies,
right?
And preventative care, I don't see preventative care benefiting insurance companies like sick care.
Yeah.
And if some type of way they shift that to where they, preventative care costs more than sick care, I think the general public will just wait until they're sick.
Yeah.
You know what I mean? So I guess I'm just not as optimistic because, until people just wake up, it's kind of like the NCAA, right? And for y'all, listening, I'm not, I give sports, parallels, and something that happened recently is the NCAA allowed college athletes to be paid.
Yeah.
But for the longest, the NCAA was a monopolist over amateur and collegiate sports and didn't allow players to be paid. But now you have things like these super conferences happening, you have these NIL deals happening, and essentially the NCAA's arm is being twisted into allowing athletes to get paid, or else they're going to lose all relevancy because these super conferences can start leagues of their own, right? So I think you would almost have to put the insurance company in that type of situation where you force their hands to where they're almost won't be relevant if they don't make a change.
Absolutely.
And right now, the way they're going, I don't see them incentivizing preventative care to where it could swing the pendulum.
And I agree, but I think you said exactly what people oftentimes need to hear. It's not relevant or it's not possible until it is. Right? If you talk to somebody and you know this way better than I ever will, your brain for sports is, like a vault. When was the Fab Five from Michigan? What years, ballpark?
It's 90, 91.
Okay.
Around that time.
So if we're telling somebody in 1995, 98, that, hey, college athletes are going to be paid someday, what do you think the response was?
No way.
Not even close.
Right, not even close.
What are you smoking? More than that.
Right.
So people 20 years ago or 30 years ago, when we were children, were saying the same thing, but the momentum wasn't there. But if you keep going and enough people really and truthfully catch on, things can change.
I agree.
Right? I think healthcare is like that. The problem is you're going to have the people who make the most money aren't going to just say, yeah, you can take my money, right? No one's going to say, I'm making billions off of you. I'm okay with having less. They're going to say, absolutely not. The system is great. And look at all the things we're doing to make it even better. And we're building parks. We're having partnerships. We're doing all this stuff. And yet the same people have the worst outcomes. And you know who those people are.
Right.
They look like you and me.
Right.
And those people are the ones that are sick, damn near dying, if not dying frequently. And yet we keep telling people, well, it's just the way it is, right? And shout out to my oldest brother, Purcell, if you're listening, what up? One of the things that he told me and taught me a long time ago, the definition of oppression is making people feel that nothing will ever change. And when I learned what that meant, and this wasn't when I was, 4 or 5 years old, this is when I was in college, right? He was just like, you feel like that because they're doing it to oppress you. They want you to feel like you can't make a change. And when you feel that, you give up. So the goal for these entities, the NCAA being one of them, was to give them the most oppressed feeling ever, that this is the way it is and no matter what you say, it ain't never going to change, for you to quit. But the people who really and truthfully saw the amount of value they were bringing in but not getting, got momentum and got together, and they partnered and paired and did everything they can to organize, mobilize, and strategize to make a change.
Gotcha.
So you telling me athletes, which love sports, but last time I checked, that doesn't save lives. You're telling me athletes can figure it out, but the physicians, the smart people, the healthcare executives can't? Please. I think what it is, as you just said, people are oppressed, but they're also disincentivized to keep things the way they are.
Right.
And this story really and truthfully made me say, look, other people do it. Why can't we? Well, what it is most people don't want to, or most people are kind of okay with being where they are. They're okay with being not okay.
Right.
So when you're saying, look, you said, look, I may be skeptical. But then in the same sentence, you said, but this other institution, they did it. It kind of tells you, as soon as your brain unlocks, that it can be done.
It's possible.
It's possible, right?
Yeah.
Now, is it easy?
No, absolutely not.
Right? If it was easy, everyone would do it. And I say that all the time. If it was easy for you to be a business owner and make $1 million, everybody would be a business owner.
Right.
If it was easy for you to be a professional athlete,
everybody would be a professional athlete.
So if it's easy for you to change a broken healthcare system, everyone would change.
Well, and I think that's why it's important that we're discussing this, because if we can keep our eye on what's going on across the pond over there, maybe we can replicate some of these same things.
Yeah. And that's why I said overall for me, the idea of them saying we want to limit it to 25 people a day, we want to be paid more for the quality of care we're delivering and less for the quantity of care we're delivering. Those things are very relevant and obviously a common theme from over there to over here. And I think the big part of what you're mentioning is what drives those two things mostly. It's a system or a group of people who are nowhere close to the patients, right? You have a third party who's involved that is saying straight up, we're going to limit, we're going to dictate, we're going to mandate, we're going to do all these things that are going to cause you more work and hopefully we'll get better outcomes. Yeah. But it doesn't really make sense. So that's why I think, again, when the person says, hey, how are these things relevant to me? It's a downstream effect that a lot of people aren't surprised to know that seeing 40 people a day, seeing 50 people a day, you can't give really good, high quality care when you have those many people being rushed through a clinic visit. So going down to 25 a day is more realistic that you can get that many people in a day, whether that's 12 people in the morning, 12 people in the afternoon, 13 people in the morning, 12 people in the afternoon, right? I think that sounds more realistic.
And that's still a lot.
Yeah.
That, like, if you really think about that, I come sit here, my appointments are like an hour. So if you work an 8-hour day, you got to see 25 people. You're still expected to see like 3 or 4 people in an hour.
Yeah.
That's still a lot.
Yeah, and that's going back to the 15-minute visit, right? If there's 4 15-minute slots in an hour and you have a 4-hour morning, it sounds more realistic that you can see 12 people. Sounds more, you're still not accounting for when people are sick. You're not accounting for when people have more complicated health backgrounds. You're not accounting for language barriers where people don't speak the same language and you got to have a translator in the room. No, nobody's thinking about that. They're thinking about it, again, in a very straightforward snapshot, black and white manner. You have patient comes in, you can solve their problem in 15 minutes because you're a doctor and they're a person and everything else should make sense. No one's thinking about the variables to say, does that really happen?
Or truly, like, do you even have 15 minutes? Because, again, I don't know exactly what you do, but I don't think that is that possible to where you could just show up, talk to a patient for 15 minutes, job done, and then talk to another patient for another 15 minutes. I would assume there have to be some type of paperwork and time put in. There'd have to be some type of, I don't know, I guess, the charting or whatever you refer to. Like I don't think you just have 15 minutes.
Right, and I think you literally segued into the third part of what the British Medical Association folks are complaining about. Decreasing the amount of administrative burden or paperwork. Because you just said it, right? People think, well, you have 15 minutes. In 15 minutes, you can talk to people, diagnose them, examine them, treat them, give them a plan of care, document all the stuff you did, send prescriptions, order labs, possibly review their vitals, their blood pressure, and then do that all over again 10, 12, 13 times in a morning. It's not humanly possible.
So you just named 10 things that you have to do with each patient. If you look at those 10 things and divide that by 15 minutes, that is 1 minute and 30 seconds for each thing you just listed out.
Right. And
that's insane. And that's with that's the 25
people.
Cap.
That's the 25 cap, right? That's what I said. And when you're really good, and I like to believe that I'm one of the better ones in my profession because I really love what I do and I take it very seriously, I had to figure out how to get faster, right? And one of the things that we taught when I was an actual faculty member in residency, where we are teaching people how to be physicians, they graduate from med school and they have to do on-the-job training. We call it residency. We have to teach them how to be faster. The word we use is more efficient. You got to be more efficient, right? You got to get out of the room because you got to see these other 12 people, these other 14 people. You got to get faster. So you're telling them to spend less time developing a relationship, being a person, and literally trying to build a bond to take care of people. You're telling them that you got to go faster, right? That's what we're telling them. And it's unfortunate because that's the way the system is set up. It's not because the people training them want them to go faster. The people training them want them to do a good job more than anything. But what happens is we only have X amount of time to do what we need to do. And if we're having X amount of time to do what we need to do, and they have to do those 10 to 13 things, but also do them in a way where it's high quality, it really just doesn't add up. The math doesn't math. And that's the problem we see, repeatedly. We're seeing people constantly say, I need to go faster. I need to be more efficient. I'm getting disciplined because I'm not as productive because I don't see the number of people that they put on my schedule, and people are leaving before they're seen because I'm taking too long. And no one stops and says, well, what all are you doing in the room that would make you go a little slower? Are you doing a bad job, or are you just not doing it as fast as we want you to?
Well, I think a lot of that, you almost got to be not personable, because you already have a very, very limited window. You don't have time for small talk. But again, building relationships with people, small talk, asking them how they're doing, asking them about their families, their jobs, and understanding what these people do and how these people live their life is part of taking care of somebody.
Taking care of them well, especially, right?
And without that, it is very, very difficult. And they're pretty much asking you to not do that because you got a minute and a half for everything you need to do.
Hey, hold on. They're generous. It's a minute and 45.
Oh, man.
So that's why I'm laughing, because you just said exactly the biggest part that I think a lot of people miss, the administrative burden, because we just talked about all the stuff that has to be done in the room during the visit, but we're not also considering what happens outside of the room. Imagine a patient calls and has a question because they didn't get it answered during the visit.
Sure.
That's technically administrative work because you can't bill for that, right? We're not attorneys. We're not billing for conversations. We're potentially only billing in certain systems for the work being done that you can send to an insurance company that they'll pay you for. So the insurance company knows that a lot of the physicians are going to want to take care of people, and they're going to do what they can to make sure people are healthy, because physicians, in the most part, are nice, caring people. They're not savages. They're basically like, I don't really care if a person doesn't get their medicine. They really want people to be healthy. So they're going to sacrifice their time and quality of life to do all this administrative work because, one, it gives patients a better outcome, but two, that's how they get paid. So based on that, we do have to account for all of that administrative work, which is what? Taking phone calls, calling people back to talk about labs, sitting on the phone with the insurance company and the pharmacy to get medicines approved and get them dispensed, handling refill requests, reviewing lab results, faxing over paperwork, reviewing paperwork faxed over to you, and the list goes on and on and on. And guess what? All of that stuff I just named, how much do you think we get paid to do any of that?
None of that.
None of it.
That's part of your 15 minutes.
That's part of the 15 minutes I'm allotted.
Yeah.
And it's not anywhere close to a room where people are being seen. And yet people are telling us, well, you already make a lot of money and you should be happy with that. And I'm not going to push back and say we don't make a good living. What I'm saying is you're expecting us to do way more with way less. And then you're telling us that that's normal. And we should be okay with it.
How much school did you go to? You better be making a good living.
I absolutely. We talked about it last, right? Like the amount of debt that you come out with, in our country at least, to then have to burn yourselves out to try to pay it back. And then you're told, like, that's the way it is. You don't have a choice. Like, it really is the true definition of oppression. And it really can make you say, look, I can go do something else. I can literally go and do real estate. And I can sell houses and have less stress, less worry, make probably the same living, if not better. And then I ain't got to work weekends. I don't have to be on call. Why wouldn't I do that?
Right.
So you start to see why people are leaving the profession, or people are saying, look, either you're going to come back to the table and renegotiate, or we're going to go do something else. And then who are suffering overwhelmingly for all of this? It's not the doctors and the physicians, if you will. It's not the healthcare providers, for the most part. It's not the insurance company. So who gets the worst of it all?
Right, the patient.
The patients, right?
Right.
So, and that's why I said it's a really bad system in both industries that we're looking at, right? In the UK and here, because you're literally having people who don't really have any say-so get the worst of it. And then we are caught in the middle, usually the physicians, because we're arguing between the patient and the third party, whoever that may be. Whether then you say, well, if you take that third party out and it's me and you, doctor, patient, more than likely we can probably get a lot more done, have a lot less paperwork to fill out. Because now, if I don't have to worry about the insurance company paying me, or the federal government paying me, or the government entity paying me, I can literally get paid for what I do. I'm more incentivized to do those things. And what do you think I'm going to be more incentivized to do? To fill your medicine, to review your labs, to take good care of you. Because if I do a really good job caring for you and doing it the way that I know I should,
I will continue to
you're
come
going to
back.
continue to come back. It's
Right.
not, well, you didn't bill the right code on the right form and send it at the right time and get it to the right person. So therefore, the work you did doesn't count. Like, I want you to think about that. I've literally had people tell me that they work in a healthcare institution and they've submitted billing to insurance companies, and 6 months after they submitted a bill, the insurance company comes back and says, the stuff you submitted doesn't count. We want our money back. I want that to sit with you. I want you to imagine you literally went to a restaurant. You literally paid the restaurant. And the restaurant says, okay, we're good. We got the money. We're good. And 6 months later, you can call the restaurant and say, I really didn't like that meal. I want my money back. And they have to give it to you.
That's insane.
You sitting in the seat, having the power and the authority to do that, would think this is great. But the restaurant, the business owner, the person doing the work, serving the food, doing all the stuff,
That's
to
terrible.
literally, it's horrible. Why would you want to stay doing that?
Right.
Why would you want to continue being a restaurant when people can claw their money back 6 months later after you've already done the work and you don't have a say so?
Right. And then the thing about it is, you gotta realize motive in that,
Yeah.
in that instance. Like, did you really mess up?
Yeah.
Or is there a crunch and we need revenue?
Yeah.
Like you gotta ask yourself. Like I'll be one of that all the time. So just looking at this, you're the expert. What do you foresee is going to happen with this?
Yeah. I foresee the short term, it's going to be a lot of people saying the same thing over and over. You're seeing stories about burnout, physician shortages. You're seeing stories about how healthcare cost is exorbitant. But then it's going to take a brave number of people and groups and organizations to come together, like the NIL push with the NCAA, and keep fighting and keep arguing until somebody either says, you know what, enough is enough. We probably can do better by these people. We probably can do better by this group, and we need to make a change. Or the other side I foresee is that people are going to give up, get frustrated, and it's just going to stay the same. I'm in the first category. You're in the first category by association, because I'm dragging you with me at this point. A lot of people are in that first category. The problem is, do you have the stomach to stay the course? Do you have the stomach when someone comes to you and says, I have a big fat check for you to literally be okay with the mediocre state of things. I'm going to pay you to be quiet. Are you going to take the check? Or are you going to say, this isn't right? I know my ground that I stand on. I know the morals, and I know what I want to do. Well, most people aren't. Most people are going to say, look, I got bills, right? How many times you think that the NCAA came out and said, hey, y'all are complaining about this NIL thing. We can literally give you funding to pay for your program, and that'll basically kill it. I'm sure there are plenty of people that along the way heard that and said, hey, I'm going to take this money because it's here today and I may not be here 5 years from now. So for me, that foresight is, look, I see the big picture. I see what's going to happen generations from now if we can make a better change. But a lot of people have to be willing to take the walk with you and willing to withstand the storm. Right? There was a amazing R&B group that had a song called "Can You Stand the Rain?"
It's a good song,
right? That song probably is timely for a lot of reasons, whether you're talking about relationships or you're talking about business, right? You literally know storms will come. This we know for sure. Can you stand the rain? Right? And if you can withstand all of that foolishness, all of the negativity, all the troubles, all of the things that are going to come with it, At the end of the day, you're going to be the person looking around saying, look, we made a huge change that's going to affect generations from now until whenever. But it wasn't easy, right? Wasn't easy to change the company mindset for the NCAA that, look, we own these players. They're amateurs, and the business that we're building is bulletproof, right? Chris Webber, Jalen Rose, and everybody else who literally was complaining about my name's on this jersey in this shop, and I can't even get $5 to go and feed myself.
Yeah.
And they're making hundreds, if not thousands, off of my name, and I don't benefit nothing.
That's crazy. They had Fab 5 G Nikes in Foot Locker.
And literally, they couldn't make money off of the things that they are being. I mean, you have to think about how hypocritical it is. But the problem isn't that it's hypocritical, is that people want you to think that somehow you're crazy when you know it's not right.
Right.
Right? They know it doesn't make sense that I'm the thing generating the revenue, but I don't get any of the money.
Right. Well, and they say, well, we're going to give you a degree.
Right.
And that's cool. That's enough.
That's what I said. And same thing, right? You're the physician generating the profit. The patients are the people that are basically giving the canvas for stuff to be actually created. And you're telling me that those two people have the least say-so in this whole equation.
That's wild.
Right? The patients need this medicine. The medicine's out, and it's the best medicine that actually will treat their problem. The physician tells you this is the medicine they need because it's the best medicine out there to treat their problem. And then the people who have nothing to do with either one of those parties comes and says, well, I hear you. However, there's a much cheaper generic medicine that I think you should do first. That's it. It literally is crazy. And that's the point where I'm saying, I think eventually things can change. Is it going to be easy, as we just said? No. But as you are looking, I'm hearing you have that thought of, yeah, okay, I get it. It makes sense.
So do our friends on the other side of the Atlantic, do they strike?
Do they? I think they should if the people don't give them things that are reasonably, what's the word I'm looking for? Reasonably more of a meeting in the middle, right? I don't think they're going to give you everything you want. That's not how negotiations work.
Correct.
Negotiation, for the most part, needs to be reasonable, where both sides hopefully win. And if both sides win, both sides can continue to do what they need to do. But is it going to happen where they're going to say, on the first day where you come with concerns, they're like, absolutely, we'll give you whatever you want. If that does, then I need to go to that negotiation school.
Thanks.
Right. Like I need to be there on day one so I can literally figure out what they did and how they did it. I think it can happen. I think they will strike, but I don't think they should if they get something that's reasonable. Will that happen overall? I don't know for sure. So if we do hear more stuff going on, then I think at that point we can come back and say, hey, we do have something that we can sink our teeth into and do it over here in America. Is it going to be easy compared to what they do? I don't know, right? Again, I'm not that great at politics per se. But what I can say is when I saw the story, once the question was posed, I said, oh, well, it's obvious that it's not just us. But the other part is that you can see when you're adding third party, fourth party, fifth party people into the equation, you're starting to hear bellyaches about, well, this doesn't make sense. Why are we working hard or working harder, receiving less for working harder, and then at the same time, you're telling us we just need to do more? Doesn't really make sense. So overall, I think, to me, to answer your question in the most emphatic way, yes, I do see it changing. Do I think it's going to be easy? Absolutely not. Do I think it's going to be soon? Probably not either. But I don't think any one of us should quit.
You know what's wild?
What's that?
I feel like every time we record one of these radio episodes, I feel like my takeaway is always the same.
And what's that?
It is if something is not working for you, do not be afraid to change it.
Thank you.
And it's every episode is wild, but and this goes deeper than healthcare. Like healthcare is obvious, right? Because insurance been doing their thing forever. I'm talking about your career, your life, your relationships, your diet, whatever you got going on. If you should be in a constant, analyzing phase, a constant evaluation type of phase. Evaluate everything that's going on in your life. If it works for you, keep it. It's cool. If it don't work for you, don't be scared to check it out the window.
Well, I think a lot of people are afraid to do that, right? And why are they afraid to chuck it out the window? For the main reason is that they are afraid of what the unknown may be. And it's not because the unknown is scary, it's just that it's unknown.
Well, there's ways to kind of do some research on that. I'm going to tell you a quick story. So when I was about 22, 22, 23, I was filing income tax. I go to H&R Block every year. Mm-hmm. And I was like, man, I went to H&R Block. They told me to get education credit. They was going to charge me $200 to do my taxes. I said, okay. Well, I'll tell you what, don't file it. Let me see the total. I went online to do my own income taxes. Mm-hmm. And I got the same exact numbers. But it was free for me to do it.
Yeah.
And at that point, I started doing my own taxes.
Yeah.
You know what I mean? It just didn't make sense for me to pay somebody else. And look, but I did tell them to save it because I'm going to go try this. If this don't work, I'm coming back. I'm going to give you your $200. But I say that to say sometimes you don't have to just jump in the pool.
Yeah.
You can put your foot in the water and check the temperature.
Yeah. Yeah. And I think, again, sometimes the fear of the unknown is more of a thing than the failure.
Yeah.
Right. And sometimes stepping into that unknown, you may actually realize that that's where you were supposed to be all along. And sometimes people have to get that courage to step into something different. So when we have people that sign up with us in the DPC model, try something different, a lot of them are pleasantly surprised and they love it and they stay. If we have people who don't, that's okay too, because at least you say, look, I tried, it wasn't a good fit for me. So my hope is that with our partners over in the UK, they'll potentially come back to the table and say, look, we did the negotiation. We got more things that we needed. We have a better work-life balance. We have more return for the work we're doing. We're not strapped with all this administrative stuff that is just really not purposeful. And it can be a catalyst for things over here. Will it actually make a huge difference? We don't know, but we're rooting for you is my thing, right?
Agreed.
So I think at this point, we'll go ahead and slowly but surely close out. So George, we'll cue up our quote and then we'll come back and give your closing thoughts if you don't mind.
Hi, Dr. Jasper. I just wanted to say thank you so very much for discussing the issue of physician shortages in your recent episode. As a pediatrician working for a large hospital system, it was a timely discussion for me to hear. I also know there are many other doctors out there who need to hear it as well because we are all facing burnout from this broken health system and so many other things that come with it. That episode gave me the courage and push I needed to explore going into business for myself and possibly doing direct primary care as well. So please keep sharing your knowledge and experiences. There are many of us who are rooting for this show to keep going and keep growing.
All right, so I think that was, again, short and sweet, and we're switching it up. Sometimes we're going to let the quote roll out with the outro music, but sometimes we'll work it in just to make sure people are listening to the tail end. But at this point, we thank you all for listening to episode 10. George, where can the people find you before we come back for episode 11? Yeah,
on the X platform, you can find me at George_Becnel, and on Instagram, you can find me at Becnel Media.
All right. And for us, you can find us at our website, www.byja.org, byja.org. You can also find us on Instagram and Facebook at Byja Clinic. We're also on LinkedIn. And then finally, you, of course, can find us at our amazing radio show with the one and only Patient Zero. So I'm Dr. Jasper. We will close out and we will see you all next week.